My name is Dr. Wilfredo De Jesus, and today we'll be talking about HHT, pediatrics, and COVID. I want to say thank you to HHT Canada for the invitation. And the presentation that we'll be discussing today is an adapted version of a presentation that was presented at Cure HHT, and this presentation had permission of Dr. Andrew White and Dr. Adrian Hamill. So let's talk about HHT, pediatric, and COVID-19. So first, for those that doesn't know who I am, I'm Dr. Wilfredo De Jesus. I'm a pediatrician and also a pediatric pulmonologist at the University of Puerto Rico Medical Science Campus. I did my fellowship in pulmonary at the University of Texas in Houston. And actually, I'm the director of the Rare Pediatric Lung Institute in Puerto Rico. So in that institute, we have HHT pediatric clinics, and we take care of patients from 0 to 21-year-old with HHT on the island. So the goal of this presentation will be, first, we would like to review the pediatric HHT DC and the clinical findings associated with the DC. We would like also to provide an overview of the pediatric recommendations included in the 2020 International HHT Guidelines. We'll review how to use the pediatric checklist in HHT. That is a very informative document that we can have available to our patients in the clinic, and also will provide a lot of information about how you should manage the HHT-DC. At the end, we'll have some question and answer from the audience. So I know that most of you may heard about the HHT before. So HHT stands for Hereditary Hemorrhagic Telangiectasis, and we know that this is a genetic disorder that is described as an autosomal dominant disease. That means that when we find a patient with HHT, it's probably that the parents also have the disease, or also somebody in the family. So this is why it's important to screen patients in the family in order to detect who has the disease or not. Also, the prevalence of this disease is 1 in 5,000. So although it's a rare disease, we know that it is present in many countries, and Puerto Rico is not an exception. So we have patients on the island with HHT, and it's characterized by vascular malformations. And those malformations can occur at the skin, the gums, the mucosa, the internal organs, and that could be also brain, lung, liver, and also the nose. Or sometimes the disease is underdiagnosed. That means that most people with HHT may be unaware that they have it, okay? And because not too many people can recognize the association between bleeding and HHT, a lot of people are not diagnosed as early as we would like to in order to prevent comorbidities over time. So a long diagnostic delay is common. Some people can last like years to decades in order to get adequate diagnosis. So that's what we would like to do in order to diagnose early our patients. So increase awareness about HHT, like the way you do in HHT Canada, is very important, because sometimes doctors and the community, they don't know about HHT. So one of the most important things is education in the community. So the most common symptom is nosebleed, or the medical word for nosebleed, that is epistaxis. And that's something that worsens with age and not necessarily appear as the typical telangiectasia. Sometimes the bleed could be like a daily bleed, but sometimes could be intermittent. So it depends of the age of the patient, and the amount of the bleeding that the patient has also could be related with the location, if it's the humidity and the related things that patients do. Also, we have a diagnostic criteria for HHT that is called the Curaçao criteria. And we will have another slide that will be discussing that. But in general terms, we can use a test that is called genetic testing that we can easily be performed. And what help is that with the genetic testing, we can identify the specific mutation and which gene can be affected in that particular person. So the Curaçao criteria take in consideration some points. One is the epistasis, the nosebleeds. Sometimes it's a spontaneous nosebleeds, recurrent nosebleed that could happen, like I said before, every single day or intermittently. Also, the presence of telangiectasias. And telangiectasias could also appear in the lips, the oral cavity, finger, nose, but that is an important criteria too. And the third one is that patients have like involvement of telangiectasias in different part of the body inside the internal organs. For example, the gastrointestinal tract, the lungs, the liver, the brain, and the spinal cord. So if there is an arteriovenous malformation in any of those organs, we can increase the criteria or take in consideration that criteria in order to make the diagnosis of HHT. The fourth point is that there is a family history of HHT. A first degree relative with HHT would be also a point in the criteria for the Curaçao. So let's say a patient have less than 2 criteria. So that means that the patient have probably unlikely the presence of HHT. But if he has more than 3, like 1, 2, or 3, the criteria will tell us that there is a definite diagnosis for HHT. If it's just 2, we can suspect that. So in that case, I probably will consider to do genetic testing, because if you don't fulfill with these criteria, you can also do genetic diagnosis with a genetic test in order to make the diagnosis and see if the patient have a genetic disorder. Okay, so sometimes there are some questions about if this could apply with the pediatric population. And because we're talking about HHT in pediatric, what we would like to discuss is how the Curaçao criteria will help us to diagnose HHT in pediatrics. So what happened is that in this study evaluated the Curaçao criteria for the diagnosis of HHT in the pediatric population with a family history of HHT. So with this data, we know that if we use the Curaçao criteria, we'll be able to diagnose HHT in pediatric with a sensitivity of 68% and a specificity of 98%. So it's pretty good in order to diagnose HHT in pediatrics. So we are still using the Curaçao criteria in our clinics, and also the genetic testing. So the manifestations of HHT, as I said before, are the telangiectasias. So the telangiectasias could have something different between adults and children. For example, we know that 95% will have telangiectasias before 40 years, and also 30% before 20 years, that they may occur at the face, lip, ears, hand, nasal, oral mucosa. But in children, the typical findings as the one that we can see in the books of, for example, this adult patient have a lot of tiny red capillary telangiectasias in his lips. So, but in pediatric could be just one, and that one is the only clinical manifestation that the patient has in the skin. And sometimes patients think that this is not a telangiectasia, that this is like, for example, that they bite the lips, and probably that's as a result of the of like an hemorrhage, but that's not the case because that telangiectasia is still for a long time, forever in the lips. Okay, so that's the difference how we can differentiate other causes of redness of the skin between a telangiectasia. Also in the tongue. So adults will present more severe manifestations, but the kids or children will just have one of those little spots here in the tongue. So that's why as a pediatricians, we have to be very careful during the examination because sometimes that specific spot could change or could add another criteria, another point in the criteria for the Curaçao and make the diagnosis. So we have to look very careful on the oral cavity in order to make sure that we are not missing any lesion. Okay, the same happens in the skin. In adults, you can see a lot of red dots or telangiectasias, but in children, sometimes you can see something like this, and you will ask, "What happened here?" And they will say, "Well, maybe it's a mosquito bite." So it's very difficult in order to differentiate, but as much as you see, probably you will be more familiar of how notice this in the skin, in the lips, in the tongue of our patients with HHT. So next is the nosebleeds. So nosebleed, we know that 95% by age 40 will have a nosebleeds. Most of them, this is like the most bothersome symptom, and the average age of onset is 12 years. May begin in infancy, sometimes it's profuse or sparse, sometimes it's oozy or hemorrhagic. It could happen daily or rarely or never, sometimes. But in children, we know that 33% will have by age 10-year-old an episode of nosebleed. Okay, so the other part of the manifestations that could happen in patients with HHT and in pediatrics too are the pulmonary arteriovenous malformations. So we know that in adults, it's like 55% will have a pulmonary arteriovenous malformation, and those are present with cyanosis or exercise intolerance, low oxygenation, pulmonary hypertension, headaches also could be part of the problem. But in children, 20% could be presenting with pulmonary arteriovenous malformation and could be asymptomatic. Sometimes they don't have any of the symptoms related with pulmonary arteriovenous malformation. That's why it's very important to screen patients for pulmonary malformations. Sometimes, and depend if the patient have like history of asthma, sometimes the malformations could be confused with exercise intolerance as mistaken for asthma. And also they may have bluish discoloration in the tongue, in the fingers, because of when they do activity. But the concern that the pulmonary arteriovenous malformation could cause a stroke is rare in pediatrics. Okay, we have different types of pulmonary arteriovenous malformation. The most common ones are the simple arteriovenous malformation, that there is a connection between the artery and the vein, and there's some severity from A, B, and C, where C is more severe pulmonary malformation. But also 10% could be complex, that involve more than two branches of the pulmonary circulation, and the complexity of these malformation could improve or could affect more the oxygenation of the patient. This is a case from our clinic. It's a 16-year-old pediatric case that have an endoglin mutation from Puerto Rico that present with shortness of breath with activity, with exercise. So he likes to play basketball, but as soon as he started playing basketball, what happened is that he was short of breath and has to stop. And because of the symptoms, he came to the clinic and we were evaluating the patient with pulse oximetry, and the saturation of the pulse oximetry was 93%. And usually the saturation should be more than 95 if we don't have any pulmonary issue. If it's 92, 91, 93, probably there is something wrong that we should look for. So we completed a chest CT, and the chest CT is a picture of our lungs in detail, and that CT revealed a lesion that was concerning of a pulmonary arteriovenous malformation. And when we did a reconstruction in 3D, we saw the pulmonary malformation, and that pulmonary malformation was embolized, and the results were pretty good. The patient, after the embolization, the saturation increased to 98%, and he was able to start playing basketball again without any shortness of breath with activity. So that's the treatment, right? So what we do is we consult our cardiologists, interventional cardiologists, and they will use some coils inside the arteriovenous malformation, and that will help to decrease the connection between the artery and the vein, and then the oxygen will improve. So also something that could happen are brain malformations. So brain malformation are central nervous system manifestations. It occurs in 10.4% of adults could have a vascular malformation in the brain. In children, we don't have a lot of data about that, but there's some reports that said that it's from 9.6% to 25%, and the surgery or the treatment will be surgery versus embolization and radiotherapy. On those cases, as you can see on the image, because of the severity or the complications associated with these, we involve very soon the team from neurosurgery, and they are the ones that will consider different treatments like the ones that we spoke, surgeries or embolization. So one of the most recent international guidelines that we would like to discuss have a section specifically for pediatric care. And because this conference is about HHT and pediatric, so we should take time now to discuss the 6 recommendations that the international HHT guidelines published in the last year. So there are 6 recommendations and are the first ever HHT guidelines for children. So before we didn't have specific guidelines that apply for children, but because of the work from all the researchers in the labs and HHT and our clinics, now we have more information on how we should manage children from newborn to age 18. So the recommendations address specifically how we should diagnose HHT, how we should screen and treat pulmonary arteriovenous malformation, and how we should screen and treat brain malformations, okay? So let's start with the pediatric recommendation number 1. So the expert panel advised that diagnostic genetic testing be offered for asymptomatic children of a parent with HHT, and that had a quality evidence of 96% and a strength of recommendation for 94%. So that's pretty strong recommendation. All these recommendations, in order to be considered as a recommendation, has need to be above 80% in terms of quality of evidence and strength of recommendation from the panel that revised all the recommendations. So you will see that there is no other recommendation that with less than 80%. So what this means? So this means that we should consider on any asymptomatic patient from a parent with HHT to consider and order the genetic testing. So in our clinic, we test for these genes that are included in a commercial HHT panel that include ACVRL1, endoglin, RASA1, SMAD4, but also include other genes that are associated with other diseases in terms of capillary malformation syndrome and Parkes-Weber syndrome that could present with some of these of the clinical symptoms of patients with HHT. But because it's included, we take advantage of that, and then we send the genetic testing for this group of genes. So recommendation number 2. So the expert panel recommend screening for pulmonary AVM in asymptomatic children with HHT or at risk for HHT at the time of presentation or diagnosis. This has a moderate quality of evidence with 94%, and the strength of recommendation is strong with 94%. So screening for pulmonary AVM. So how we do it? So we have the clinical consideration would be to either complete a chest X-ray or let's remember. So we should do a chest X-ray or pulse oximeter or a transthoracic cardiac echocardiography. So that's also called the bubble echo. Is that image that you can see here? That is the is a echocardiogram doing with contrast. And when you do a contrast cardiac echocardiography, you will have a lot of bubbles inside the heart, and that kind of specific amount of bubble will let us to understand the degree of the problem in terms of the pulmonary venous malformation, arterial venous malformation. So if we have a suspicion of the pulmonary venous malformation, what we do is we do a chest X-ray and oxygen assessment, and or we will do a transthoracic contrast echocardiography. And depending of what is the result of that echocardiography, we will consider a chest CT or not. Okay, so the screening with a chest CT is not recommended at the beginning of the evaluation. Okay, just only if one of these are positive. So the pediatric care recommendation number 3, it says that the expert panel recommend that large pulmonary AVMs and pulmonary AVMs associated with reduced oxygen saturation be treated in children to avoid serious complications. They have a quality of evidence of moderate with 98% and a strength of recommendation strong with 98%. So what we do if we find a pulmonary AVM? So we recommend that those AVMs with a feeding artery more than 3 millimeters will be recommended for embolotherapy. So that means that we'll go to the cardiology and they will do an intervention in order to decrease the size or improve the oxygenation in that particular area. So a follow-up is indicated to detect recanalization, perfusion of treatment, and the specific protocols between how we should do the reevaluation is depend of the center that the patient is evaluated. Some patients use chest CT, some patients use follow the oximetry, and some patients do echocardiography at different intervals. Okay, so now we will have to talk about the pediatric care recommendation number 4. And in this recommendation, the expert panel recommend repeating pulmonary AVM screening in asymptomatic children with HHT or at risk for HHT, typically at 5-year interval. So quality of evidence for this recommendation is 92%, and this trend of recommendation is strong with 86%. So the clinical considerations will be First, typically a negative screening is repeated 5 years, and that's what we do in our clinics in Puerto Rico. So if we diagnose a patient, we complete the initial evaluation, and then if everything is negative, we will wait 5 years in order to repeat another baseline evaluation. Sometimes the patient may have um, another symptoms prior to 5 years. So in those patients, you will reevaluate everything again, but depend of what type of patient and what type of symptom severity the patient have. So in children with intermediate or borderline screening results, depending of the imaging or oximetry, we can do it sooner. So we don't have to wait if it's borderline at the beginning. So let's say that the saturation was 96, 95%. So we would like to check maybe in 1 or 2 years, how is the screening again, in order to avoid missing a diagnosis that could have some implications over time in terms of management or treatment. Okay, so let's say that the fifth recommendation is that the expert panel recommend a screening for brain malformation in asymptomatic children at the time of diagnosis. Okay, we saw that depending on the imaging, the MRA of the brain, then we can see some vascular malformations. So those will benefit for a surgical or endovascular management because of the risk of bleeding. So what we do is at the time of diagnosis, we will complete an MRA in order to make sure that our patient doesn't have any vascular malformation. And if it's negative, then we'll wait 5 years and we'll do it again. And so that's the first line, screening with an MRA, but it's an MRA with contrast. It's contrast enhanced sensitivity to identify brain malformation and determine the subtype and risk factor for MRA. Sometimes in pediatrics could be difficult to do an MRA, okay? So most of them will require sedation with the team of anesthesia in order to have good quality images and see the parenchyma of the brain with detail and in high resolution. So we have to make sleep the kids. So then the pediatric care recommendation number 6, and this is the last one, the expert panel recommend that brain muscular malformation with high risk features should be treated. So quality of evidence for this is 100%, and the strength of recommendation is 98%. Because the clinical consideration here is that given the need to balance natural history with treatment risk, the children with HHT who have brain vascular malformation should be referred to a center with multidisciplinary expertise in neurovascular disease management. And those high-risk features are criteria that the neurosurgery team has and that they take in consideration to understand the risk associated for bleeding if we don't do any intervention at that point. Okay, so could be related with the size of the lesion, of the vascular malformation, and the location. So as soon as we find brain vascular malformation, what we will recommend is to be evaluated with a neurovascular team at a multidisciplinary, using a multidisciplinary approach. So this is the summary in a table about the 6 recommendations that we already discussed. First, we will offer the genetic testing for asymptomatic children of parents with HHT. We'll screen for pulmonary AVMs in asymptomatic children with HHT at the time of diagnosis. 3, with those with large pulmonary AVMs and those that have associated low oxygen saturation should be treated in order to avoid further complications. 4 will repeat pulmonary AVM screening in asymptomatic children in 5 years interval if everything is normal. And 5 will screen for AVM at the time of diagnosis. And 6, those brain AVM with high risk features, including location, should be treated by neurosurgery. So the resources for these HHT guidelines and the pediatric care guidelines for HHT could be found at this website, www.hhtguidelines.org. And also there you can find some checklists that are very important we'll be discussing next. But if you find these guidelines important and helpful, just take a copy with you and share the guidelines with your family, with your doctors, with your healthcare providers, nurses, because the more people know about HHT, the more we can help people be diagnosed earlier. So for when you go into this website, you will find the pediatric HHT checklist. So this checklist is very useful for the parents, because if you can see here, you will have my child HHT care checklist. You put the date, the child's name, and also you'll be able to check on these boxes. If my child has a parent with HHT and we don't know if my child is affected, so what I should do? So I should talk with my child's doctor about genetic testing for my child. So that's guideline number 1. And the same thing, you can go at different boxes here. For example, does my child has brain vascular malformation? So ask for a referrer for multidisciplinary expert neurovascular team for assessment of my child. So that is a summary. This checklist is a summary of the guidelines we already discussed. And if you just print this and have that piece of paper as part of your management of your child, you already will be checking all boxes in order to be completed that you already went through all the details in the HHT guidance, okay? So there is guidance for children's, but also there is a guidance for adolescents. So my teen years HHT care checklist. So you'll have the teen's name and you will go through all the boxes. And if that box applied to you, they provide some resources or information about how you should address your DC. For example, I have a lung AVM. So if the teen have a lung AVM, just click that box, and then you should talk to my dentist and other healthcare professional about the need for a lung AVM precautions, for example, antibiotics, for example. So this is, I think this is a very helpful guide in order to have as part of your medical record. And that is how you should go one by one and try to check if you have that or not, and make sure that your child is already covered and you already discussed all these in detail with your doctor. So last part of my presentation is talk a little bit about HHT and COVID-19. And because of this pandemic, and we should not go through the end of this presentation without talking about the implications of having COVID and HHT with the HHT community. So what we know is that not just with HHT, but with all the rare diseases, the information that we have related with COVID-19 may not be robust so it's limited. But there is some articles that I found that I would like to discuss with you, and one of these is this one called Angiogenesis, Hereditary Hemorrhagic Telangiectasia, and COVID-19, that was published in 2020. And that study had a 27-item survey that captured clinical data for admitted HHT patients with COVID-19 last year. And only the interesting part is that only one of 1,000 HHT patients that were admitted with HHT had COVID-19 pneumonia. And that was a 74-year-old woman with a pathogenic variant in the ACVRL1 gene. And the clinical course of this woman didn't involve any mechanical ventilation or any worsening epistaxis or nosebleeds. And she was successfully discharged after 2 weeks. So just looking at this article, I can say that the COVID-19 may not be as bad for the HHT community. Of course, we have to still take in our care and following the instructions for the health department. But that's pretty good news that in 1,000, just one patient had a COVID pneumonia. That's pretty good. Reason for the low prevalence of COVID-19 in HHT patients? Well, as all patients with chronic diseases, HHT patients could have self-isolated more strictly than non-HHT patients due to fear of COVID-19 therapeutic measurements that may have worsened their recurrent epistaxis. So that's a theory, right? So the same happened with other diseases like cystic fibrosis or primary dyskinesia. So HHT patients, they know that they have a disease, a chronic disease, and take more precautions, right? So they probably had more precautions than the general population, and for that reason, the findings that we already discussed. There is another study, it's a retrospective study that evaluated 138 HHT patients at the ENT reference consult in an ENT doctor, an otorhinolaryngologist. And the evaluation of the COVID-19 infection reveals that mild symptoms were reported after infection of with COVID-19. So among the 25 HHT patients who were infected, only 3 cases were hospitalized, and none of them required ICU or intensive care treatment or mechanical ventilation. So mild symptoms is good too. And there's another survey. The survey was conducted at the 14 HHT US Center of Excellence HHT centers. So they found about 40 cases with COVID-19 and HHT, and they described them as most cases were mild. Okay, one patient has a myocardial infarction, one patient has a small stroke, 2 patients had it COVID-19 related death, but those patients were having another multiple medical condition, not necessarily was because of HHT. And there was no history of pulmonary embolism or deep vein thrombosis. So overall, the HHT community and the science, the doctors in the US Centers of Excellence, they said that the data showed or that data do not show increased risk of COVID-19 in HHT patients. When we look inside this article, we can see that they publish a table with all the cases that they described. So because this is a pediatric conference, I took into consideration discussing the 3 pediatric patients that were presented in this publication. So 2 of them were females, one with endoglin gene, 2 with ALK1 or HHT2, One has a history of pulmonary arteriovenous malformation, and the age of these three patients, so only three pediatric patients in that cohort, had 16, 18, and 16-year-olds. So they were adolescents. And the patient 19, however, the symptoms were nothing, were asymptomatic. None of them required hospitalization. Patient 22 is adolescent or almost an adult, had infected twice, and the only symptom was rhinitis. Patient 24 had fever, vomit, tiredness, and breathless, but was not admitted to the hospital. So that is even good news for the pediatric population, because on this case, a study, we didn't have too many patients less than 18-year-old with symptoms of HHT. With symptoms of COVID-19 associated with HHT. Okay. So this is what I have for the talk this afternoon. So if you have any question, you can let me know, and I will be happy to answer those questions.
Okay.
Thank you, Dr. Wilfredo. That was an excellent talk, very informative, and I'm sure a lot of HHT patients who plan on conceiving or who have kids, it's going to add a lot of clarity and peace of mind to them, because that was very informative. If anyone has any questions, please unmute yourselves and proceed to ask the question.
Sure. I have one quick question. Thank you for the presentation. I really liked how you organized it into 6 main points, and then critically evaluating the existing evidence and recommendations made it really easy to follow for me. So the question I had was that early on you mentioned that there's like benefits of early diagnosis, and that this might be a more basic level question, but what are some benefits or comorbidities that could be lessened with early diagnosis of HHT in children?
Yeah, that's an excellent question, because most of the problem that we have is that when you don't recognize that you have HHT, and somebody tell you that, oh, it's just because you have nosebleeds every day, you don't verify if you have all these other malformation inside the different organs inside your body. So when we have the diagnosis, if you see the guidelines, we should start looking for those malformation in interval period of time. Mm-hmm. And when we are able to diagnose malformation in the brain before the patient has already symptoms, we can treat that early on and avoid a stroke, for example. Mm-hmm. Or we can avoid a liver problem because we identify that before the symptoms started. Remember that as soon as the symptoms start, it's because there is a severe problem of the involved organ. So the earlier we can diagnose, the best is the long-term improvement of the comorbidity, or the avoidance of the comorbidities. That's the most important thing to do. And when I talk with my patients, I said, well, now that we know that you have HHT, and that's the reason for your nosebleed, we can track your pathway, and we can make a plan, a personalized plan, in order to see what we should do over time, and not looking for other stuff that are not necessarily needed. We have guidelines. We can address those guidelines, and we can take care of you in a better way.
Gotcha. So it's like prevention of more serious like complications, and also developing that personalized plan in order to,
that's correct.
Preventative medicine. Yes. Awesome. Thank you.
Hi, thank you for an amazing presentation on both pediatric HHT and also for talking about the prevalence of COVID-19 in the HHT community. I do believe there's a bit of lack of information, especially when it comes to rare diseases. So I found your presentation informative. So in your presentation, there was quite a bit of an emphasis on the benefits of screening children of patients with HHT, and even if they were asymptomatic, I believe. Now, I believe these guidelines that were proposed were for developed countries which have access to medical screening technology like genetic testing and such easily. What about countries that are still developing? Do you think such guidelines should still apply for countries that don't have easy access to genetic or non-genetic testing? Should those communities also follow the same guidelines?
Excellent question, because sometimes we think that everyone have access to a doctor that is knowledgeable about HHT. Second, about the technology that we need in order to diagnose all these comorbidities and to follow all these guidelines. Remember that these guidelines are created internationally, but in centers that they have a lot of resources. But let's talk about Latin America. Latin America may not have access to all these technology, MRAs, CT scan, or maybe limited. So there is a challenge how we could implement these guidelines in those countries. So I don't think that will probably apply to everyone, but that's the goal. No, that's the goal to do it, because at the end of the day, the quality of care should be universal, and we should be able to diagnose HHT in every country and provide the same quality and standard of care globally. So that's the challenge that all these leader groups with HHT Canada, HHT Puerto Rico, HHT Latin America, we should look forward to improve, and the guidelines could be applied to everyone, but that's something that we have to work together globally.
Thank you very much.
Any other questions?
Yeah, I had a quick question. So it might be a little bit more on the basic side, but if you're a parent with HHT, when do you think the best time is, or like what age should your child be to get diagnostic genetic testing? Is it as simple as early as possible, the better, or is there a specific age maybe?
Actually, that's a pretty good question that parent may have, and my recommendation and the guidelines said that as soon as the parent is diagnosed, we should look for other in the family, and that's something that happened in my clinic every time. Every time we diagnose one person, we screen the other ones, no matter what age it is, because the genetics will not change. So maybe the patient would not have the symptoms yet, but we can plan together as a family who has the disease in the family and who doesn't. So the earlier, the better. So all patients in the family or all people in the family will be screened for genetic testing at the time of the identification of a parent with HHT.
I see. Okay, thank you.
Hi, so I have another question. So thank you, Dr. Wilfredo, for amazing presentation. It was very informative to learn more about the current guidelines, and early diagnosis is key for rare diseases such as HST. So it's very informative to know about that. My question may also be a little bit more on the basic science side, but you outlined some different genes that are involved with the HHT. And I was wondering if there's a particular mutation in one of those genes that may contribute more to severe symptoms or early onset of symptom demonstration in pediatrics? And if so, are there any current ways for us to detect those mutations?
Yeah, so that's a good question, and that's something that we're working to do research on, because one of the things that we don't really know is if, depending of the protein alterations that we can see as the result of the genetic abnormality, if the symptoms will be worse or not. So one of the things that we're working right now is to do that type of correlation, right? So we are conducting a study right now in order to evaluate the genotypic and phenotypic correlation of patients with HHT. And because I'm a pediatrician and a pediatric pulmonologist, so I will be looking on the pediatric side too. So hopefully we'll have more information about that. But what we can speculate is that those that have larger deletions in the gene will have severe disease, because we'll have a protein that is completely absent. And those that have more a minor deletion or interchange between one base and the other may have some functionality on the protein. As a result, the symptoms probably will be mild. So, and that also could happen between genes, right? We know that the most common one is a mutation in endoglin gene. So in Puerto Rico, we have so far identified 2 genes in our population that are contributing with HHT, and one is endoglin, and the other one is ACVRL1. So hopefully, in the next couple of years, we will have more information to fully answer your question.
Awesome. Thank you so much.
Thank you again, Dr. De Jesus. Excellent responses to these questions, very clear. I have a question myself, though. Does the onset of puberty further impact the disease negatively? Does it contribute to it? Does it lessen the disease severity? Do you have any insight on that? Thank you.
Yeah, so puberty in pediatrics is a very difficult topic because it involves many changes in terms of hormones, estrogen, progesterones. So the actual answer, I don't have an answer for that, because we still learning about pediatric at this point, but that's a pretty nice topic that we can address in terms of severity of symptoms during the adolescent period or puberty period, because I don't think I saw any literature related with that in terms of how the hormone changes could also affect the bleeding or the presence of other symptoms. But I will take that as a recommendation for future research.
Certainly. Thank you for the response. There certainly is a lot more research that needs to be done in this field. Does anyone else have any more questions?
I have one question. It's a little more personal, but yeah, thank you, Dr. Wilfredo, for sharing your knowledge with us. And yeah, and I think thanks to like many people like Dr. Wilfredo and Anthony, like HHT is growing more awareness in Canada, in Puerto Rico, and even in the States. And I think like we're very privileged because of you guys, but like not everyone has the knowledge about it in the community. And as a person who has a basic information about HHT, if I see a family friend who I think might have HHT, like maybe the dad has like a lot of nosebleeds and their children does too, like what should I do? What's my how should I approach this? Should I tell them to go check it out? What's my role here?
That's a pretty good question, because sometimes we can do something about it. For example, depending of how much how you can address this, if it's something that if that person a friend of you, probably I will go ahead and said, well, I'm a pre-med student, or I would like to I'm learning about all these diseases, And I know about a disease of that promote nosebleeds, and I'm concerned that you have nosebleeds. You should try to. Do you ask already to your doctor about why your nosebleeds are? You can ask in that particular way. I will tell you something about something that happened in my clinic one time. In my clinic, I have some students that work with me, and when I was evaluating an HHT patient, at the end of the evaluation, the student told me, "Hey, doctor, I think that all the questions that you already asked to the patient, I answer yes in my mind to all these questions." And I said, "Well, we can test for HHT if you want." And when we did the test, at the end of the rotation, the patient was the student was diagnosed with HHT. So that particular moment when the person understood that the symptoms were related to a disease, took her to us in order to ask for help. So when you have a conversation with that person, just try to provide them the tools in order to be tested, or ask them to see if she already or her already spoke with the provider about the symptoms, because you may be the only one that could detect that and could change the way of the disease, or can help that patient in order to be tested. And if it's negative, that's okay, perfect. We know that it's not HHT related, but if it's positive, you already did something important in the life of that person.